Welcome to UMCC Medical Consultant Connectors. I'm Dr. Sanjay Gupta. Today we're focusing on gestational trophoblastic disease, or GTD, a rare but important group of pregnancy-related tumors. GTD develops from placental cells that grow abnormally inside the uterus. Most forms are benign, but they can cause complications and sometimes become cancerous. When GTD turns malignant, it's called Gestational Trophoblastic Neoplasia, or GTN. Even the cancerous forms are highly treatable, especially if caught early. GTD is linked to genetic errors during fertilization, such as a sperm fertilizing an egg with no genetic material, or two sperm fertilizing one egg. These errors lead to abnormal growth of placental tissue instead of a healthy pregnancy. Risk factors include maternal age, under 20 or over 35, and a previous history of GTD. Understanding these basics is the first step in recognizing and managing this condition. Early detection and close monitoring are crucial for the best outcomes. Let's explore the different types and what they mean for your health. Knowledge empowers you to make informed decisions about your care. GTD includes several types, the most common being the hydatidiform mole or molar pregnancy. There are two main types: complete moles with no fetus and only abnormal placental tissue, and partial moles with some fetal tissue that isn't viable. Most molar pregnancies are benign but can lead to more serious forms. Malignant forms are called Gestational Trophoblastic Neoplasia, or GTN. Invasive moles grow into the uterine muscle but rarely spread far. Choriocarcinoma is a rare, aggressive cancer that can spread to organs like the lungs and brain, requiring urgent treatment. Two other rare types, placental site trophoblastic tumor, PSTT, and epithelioid trophoblastic tumor, ETT, grow slowly but may spread and need specialized care. Each type requires a tailored approach for diagnosis and treatment. Early recognition and intervention are key to successful outcomes. Let's look at how these conditions present and how they're diagnosed. Early symptoms of GTD often mimic normal pregnancy, making detection tricky. The most common sign is abnormal vaginal bleeding in the first trimester. Severe nausea, vomiting, and passing grape-like cysts can also occur. Other warning signs include a uterus larger than expected, early high blood pressure, and symptoms of an overactive thyroid. These are caused by high levels of the pregnancy hormone, hCG, produced by the abnormal tissue. Diagnosis starts with a pelvic ultrasound, which can reveal the classic snowstorm pattern of a complete mole or a thickened placenta in partial moles. Blood tests measuring hCG levels confirm the diagnosis. Levels are usually much higher than in a normal pregnancy. Tracking hCG is also essential for monitoring treatment and detecting recurrence. Early recognition and prompt testing are vital for effective management. Next, let's discuss how GTD and GTN are treated. Treatment for most GTD cases begins with surgical removal of abnormal tissue, usually by suction dilation and curettage, D and C. The goal is to clear all molar tissue while preserving fertility when possible. In rare cases, a hysterectomy may be considered for women who don't wish to have more children. After surgery, regular blood tests track hCG levels to ensure all abnormal tissue is gone. If hCG doesn't return to normal or rises again, this signals persistent GTD or progression to GTN. Single-agent chemotherapy is highly effective for most cases that don't resolve after surgery. For advanced or resistant GTN, combination chemotherapy is used, sometimes with additional surgery or radiation. Even with spread to other organs, GTN is one of the most curable cancers, thanks to modern treatments. Close follow-up is essential to ensure complete recovery. Now, let's talk about prevention, prognosis, and life after treatment. Preventing GTD isn't possible as it results from random genetic errors at conception. However, knowing your risk factors, such as age and previous GTD, helps with early detection. Good nutrition, including adequate vitamin A, may be beneficial. The outlook for GTD is excellent. Over 80% of molar pregnancies are cured with surgery alone. For GTN, cure rates are near 100% for non-metastatic cases and remain high even with advanced disease. Most women go on to have healthy pregnancies after treatment with only a small risk of recurrence. Your healthcare team will guide you on when it's safe to try for another pregnancy and will monitor you closely. Early detection and treatment make all the difference. Thank you for joining us at UMCC Medical Consultant Connectors. Stay informed, stay healthy. For more medical insights, subscribe and share this video.